be great. Again, good morning, everyone. Thank you for being here this morning. This is the December 11th meeting of the special meeting of the Healthcare Workforce Committee. Go ahead and next slide. And next slide. Okay, a couple of things really quickly. Again, we go over this every month. This is a public meeting. We welcome public testimony. The meeting is being recorded. We do have transcription available, and if you need it, at the bottom of the Zoom feature is a More button with 3 dots in it, and if you click on that, it'll bring up another window that says transcript or captions. So if anyone needs that, it's available. Committee members, if you are able, please turn on your cameras so we can see your lovely faces. And next slide. We'll go ahead and do some introductions now. My name is Laura McKean, and I am the Senior Director of Oral Health Services and Community Engagement with All Care CCO, and also have the privilege of serving as chair for the Healthcare Workforce Committee. And I will go ahead and do roll call. Committee members, again, if you could put a CM by your name, so it makes it easy to identify. And we will go ahead, and I'm going to go ahead and start with Ian.
Okay. Thank you, Laura. I'm Ian Strauss. I'm the principal consultant at Ian Strauss Consulting, a healthcare transformation consultancy, and the vice chair of the Healthcare Workforce Committee. And let's see here. I will pass this on to Elena.
Morning, everyone. My name is Elena Shabloski. I use she and her pronouns, and I am a dentist and dental director at La Clinica, which is a federally qualified health center in Medford. I will pass, let's see, Judy Geiger.
Hi, I'm Judy Geiger. I'm the Vice President of Patient Care Services at Columbia Memorial in Astoria Critical Access Hospital. Let's see, who should I pass it to? This is exciting. Megan.
Hi, everyone. Can you hear me? Hello?
We can.
Yep.
Oh, sorry. I've been having trouble with audio. My name is Megan Holland. I am a family doctor. I use she, her pronouns, and I work in the South Coast at a critical access hospital. And I am the Regional Associate Dean for the Campus for Rural Health on the South Coast from OHSU.
Thanks, Megan. I'm just going to go ahead and call on folks just because some people can't see everybody on the screen. And I'm going to go to Coy next.
Hi, good morning, everyone. I'm Koi Wu, pronouns she, her, hers. I'm the executive director of the Coalition of Community Health Clinics. I'll hand it over to Dr. Hemmons.
Morning, everyone. Dr. Hemmons, she, her pronouns. I own a group behavioral health practice in Beaverton, Oregon.
Thank you, Dr. Hemmings. Gabriella?
Good morning, everyone. My name is Gabriela Carrillo. I'm a Director of Clinical Placement at Sumner College School of Nursing.
Thank you, Gabriella. Manu?
Good morning, everyone. My name is Dr. Manu Chaudhary, and I serve as president of Capital Dental Care. Thank you for having me here.
Thank you, Dr. Chaudhary. And let's see. Current committee members, have we missed anyone? I'm thinking we've got everyone.
I see Stephanie Green.
Oh, Stephanie. I didn't see her on there.
I'm having trouble with my computer today, but so if I go out or something and come back in, that's fine. But I'm the Chief Human Resources Officer at Adapt Integrated Healthcare in Roseburg.
Stephanie. And let's see, how about our Oregon Health Policy Board liaison, Melina?
Good morning. My name is Melina Moran. I use she, her pronouns. I am the liaison between the two boards, and I am a family nurse practitioner currently working in behavioral health.
Thank you, Melina. And also, I just wanted to acknowledge that we do have 5 of our new committee members attending the meeting this morning. And we will be doing a formal introduction of these committee members at our January meeting. But we did have 5 members that were approved by the Oregon Health Policy Board. So again, we'll do formal introductions for those committee members in January. But I think it's great that they can be with us this morning and listen in on the meeting. Okay, next slide, please, Jessica. Okay, guests and OHA staff, if you could please type your name in the chat so we can just see who's here with us this morning. I know we have quite a few staff that support us that are on the meeting this morning. So we want to I just want to say personally, thank you for all the support that we get from the OHA staff. And next slide. Okay, here you can kind of see a list of who's with us this morning. I'm sure there might be even more that's on this list. Next slide. All right, quick review of our agenda today. We do have a pretty packed agenda. We're going to hear from Melina on our Oregon Health Policy Board, some OHA updates. We are going to review the 2025 Healthcare Workforce Needs Assessment. We'll look at the healthcare workforce diversity profile, and we're going to have quite a bit of time for public comment on the CCO 3.0 procurement. We wanted to get some feedback from some OHP consumers, members of the public. So I'm hoping that we will have some folks join us for that. And then we'll wrap up and talk about our meeting in January. Next slide. Okay, and next slide, Jessica. This portion of the meeting, we like to review the OHA and the OHPB health equity definition. We always do this at every committee. I do like to take the time to read this, which I'll do some now. And our health equity definition states that Oregon will have established a health system that creates health equity when all people can reach their full health potential and well-being and are not disadvantaged by their race, ethnicity, language, disability, age, gender identity, sexual orientation, social class, intersections among these communities or identities, or other socially determined circumstances. And we do acknowledge that achieving health equity requires the ongoing collaboration of all regions and sectors of the state, including tribal governments, to address the equitable distribution or redistribution of resources and power, and recognizing, reconciling, and rectifying historical and contemporary injustices. So thank you for that, Jessica. Next slide. And here we won't read all these questions, but these are the Healthcare Workforce Committee guiding questions for the equity framework. And I encourage everyone to review these when you have a moment. It is in the slide deck in the materials. Next slide. Okay. I'm hoping everyone had a chance to review the November meeting summary, and I will ask if so, were there any changes, additions, deletions to the meeting summary that was sent out to everyone? All right, hearing none, could I get a motion to approve the meeting summary? Yes, Ian,
Yeah, okay, Laura, I move to approve.
thank you. Is there
No
a second? Okay. Perfect, thank you. All those in favor, say aye. Or hold up your virtual or real thumb.
Aye.
Perfect. Okay, thank you all. Next slide, Jessica. All right. So now we are going to hear from Melina and hear about the Oregon Health Policy Board updates and any OHA updates that we might have.
Yeah, thank you, Laura. Good morning, everyone. So we just had our Oregon Health Policy Board meeting on December the 3rd. We started with our board business and welcome from Brenda Johnson, the chair. We had an update from Dr. Hoppy from OHA. The governor released her budget just last week. She's focusing on homelessness, access to insurance coverage, and behavioral health. And with the OHA, Dr. Hathi and her team has created a new dashboard called Oregon Health Forward. And this is to help broadcast the goal to eliminate health inequities by 2030. So with this dashboard, there's 3 initiatives. The first one is the KPIs, and that's to hold them accountable to their goals. Second one is a call to action to create a coalition with private sectors partnerships. And the next one is called Transparency and Belonging. And this initiative is to increase internal staff engagement and customer satisfaction. And so that dashboard, I believe, is live now. Also, she introduced and relayed that there's a new director of health policy. Her name is Claire Pierce Robel, and I hope I pronounced her last name correctly. Next, we had the member slate from the Healthcare Workforce Committee, and we voted to approve those new members. A big bulk of the meeting was spent on the OHPB's proposed priority work, and we voted for approval of this work, which this next year will be focusing on affordability, behavioral health, metrics, and CCO procurement. The last couple hours of the break or of the meeting was our town hall. And this is where we welcome members of the community to share their successes, challenges, experiences with their CCOs. We had 33 shares, oral and written, from a wide variety of people. Some themes that I noticed were focused on mental health and behavioral health, along with pediatric mental health. This also included substance use disorder funding, sober living, beds, and access. There was some shares on more access and navigation, helping with people with developmental disabilities. There was a lot of feedback on the CCOs. There was some inconsistencies in coverage, medical coverage, the referrals, having process navigating that medical process. There was a lot of talk about and applause to some of the food pantries that have helped a lot of people. So with this information, it will be compiled and then reviewed again. It was very meaningful, and I think a lot of us really appreciated people sharing, because sometimes that's hard with having medical trauma, and sharing their frustrations, but along with things that are going well. So I thank everyone who shared. There are upcoming opportunities to share too. And I believe those are posted. And I think that was it for that meeting. The bulk of it was the town hall. Back to you, Laura.
Thank you. Okay, so as far as OHA updates, I believe we're getting written updates for OHA. Is that right? Deepti?
Yes.
Okay,
That's
perfect. Okay.
Um,
We I was wrong when I said we had 5 new committee members. We have 6 new committee members because I neglected to include our student that we are going to have joining our committee starting in January. So we actually have 6 new committee members. And then we have a little bit of information on the how-to grant program. They're going to be seeking reviewers. I believe Melissa is here with us this morning. If she wants to say a couple of words about that. Melissa, are you here?
I am. Thank you, Laura.
You're welcome.
Hi, everyone. My name is Melissa Yates. I use she, her pronouns, and I'm the Healthy Oregon Workforce Training Opportunity or How-To Grant Program Coordinator. And we are here just to ask for your help. We have the current round 6 request for grant proposals is about to close. We're excited to see the number of proposals that we're going to get. We've had a lot of engagement, so we're expecting a big group. And that means we need a lot of reviewers. So we would love to have your participation. Just a little information about what to expect. Probably like a 6 to 8 hour commitment is our estimate. It'll be in January, around January 26th through the 23rd. So trying to give folks a couple weeks to turn around scores. Reviewers will have a virtual training. We'll record it to help get ease that access so people can get the training that they need. Will be available for questions. We also have a scoring rubric, which is what the proposers actually received as part of completing their proposal, so they know how they'll be scored. So we'd love to have your participation. I'll drop a link in the chat that is the form to let us know that you're interested in participating. I'll also drop our how-to program email in the chat. So if you have any questions or about the review process, or if you would like me to forward you a blurb, because we'd also love to have you help us spread the word to your professional networks. We're really looking for volunteers from a really wide range of different healthcare organizations, different fields of healthcare to take part. We get a really wide range of proposals, and having engagement from community members who are part of these fields is a really important aspect of that review for us. So I really appreciate your all's help both in the review and in spreading the word.
Thanks, Melissa. I've had the opportunity to serve as a reviewer for these grants for the past couple of years. It's a great experience. So I encourage committee members, and if you would like to participate in the process, to please reach out. Okay, next slide, please. All right. Just a quick update. We will have elections at the January 8th meeting. Officers to serve 1-year terms, chair, vice chair. I know I put out an email previously to committee members to see if anyone was interested. If you are interested, you can please contact me by December 20th. I'll stay on and just serve as immediate past chair for additional year. However, my tenure as chair has come to an end, but I've, of course, enjoyed being in this role. I will go ahead and drop my email in the chat just so it's at the top of the top of your list so you can see it. But again, please contact me if you're interested. Okay, next slide. All right, so we are now going to hear from our team at Oregon State University on the 2025 Healthcare Workforce Needs Assessment. And I believe we have everyone here. We have Tao, Veronica, Jeff. I'm not sure if I saw Arlene here, but I will go ahead and turn it over to the team from Oregon State University.
Thank you very much. Next slide, please. Yeah. So thank you very much for having us today, and we appreciate this opportunity to report the Healthcare Workforce Needs Assessment 2025. My name is Tao Li. I'm Associate Professor of Health Policy at Oregon State University College of Health. Our team has my colleagues, Professor Veronica Irvin and Professor Jeff Luck. Our research assistant is Arlene Barr. Next slide, please. In 2017, the Oregon legislature passed House Bill 3261. This bill directs the OHPB and OHA to produce a biannual assessment of the healthcare workforce needed to meet the needs of patients and communities throughout Oregon. This is the fifth such report that provides insight into workforce needs in communities across Oregon and general guidelines on how to expand and diversify the workforce. We use OHA's annotated outline to develop this report. Topics include investments in workforce development, healthcare trends and data, healthcare workforce shortages and disparities, healthcare workforce wellness and resiliency. In addition to the overall healthcare workforce assessment, we also include data analysis and discussions for specific provider types in Oregon. This year, we include a few new sections as well. This report builds on the Healthcare Workforce Committee's strategic framework and the committee's 3-strategy paper released in January 2024 on workforce diversity, workforce wellness and resiliency, and workforce development and retention. Our report compiles data, information, and recommendations from existing reports, surveys, advisory groups, and subject matter experts. We gave a presentation of this report to the Healthcare Workforce Committee in the November meeting, and we appreciate all the feedbacks provided by the committee. After the November meeting, our team continued working closely with OHA, the advisory group, and subject matter experts to collect new data to respond to the committee's feedbacks and questions. So today's presentation is focused on these updates we made since last meeting. Okay, thank you. And this report includes the continued and new recommendations since the previous assessment on increasing culturally and linguistically responsive care in Oregon. We summarize these recommendations into 4 broad themes. More data and examples can be found in our full report. Next slide, please. The social determinants of work is a new section this year. The social determinants of work framework describes an interconnected web of challenges that workers must navigate to arrive and thrive at their workplaces and achieve economic mobility. As shown in the figure on this slide, examples of social determinants of work include job flexibilities, childcare, and home and community health, such as stable housing and safe environment. Lack of affordable housing impacts recruitment and retention, especially in rural areas, and lack of reliable and affordable childcare and transportations are also barriers to employment in the healthcare workforce. Addressing these social determinants for workers' experience inequality is important to healthcare career entry, advancement, and retention. We have some examples in our full report. Next slide, please. Oregon has made a concerted effort to invest in the expansion, retention, and diversity of the healthcare workforce using multiple strategies. OHA's Healthcare Provider Incentive Program offers financial incentives to increase workforce diversity and capacity in rural and medically underserved regions of Oregon. The program offers loan repayment, loan forgiveness, scholarships and career pathways, and rural medical practitioners insurance subsidy incentives. As of June 30th, 2024, the program has a total of 7,735 recipients across all incentives since 2018. The number has doubled since the 2023 report. In addition to the healthcare provider incentive program, Oregon has several other programs that focus on increasing the capacity, retainment, and diversity of the healthcare workforce across a variety of providers. We included more information and examples in the report and appendices. Next slide, please. The Healthcare Workforce Reporting Program collects data of healthcare workforce during their license renewal process. These data are an increasingly useful source of reliable information about Oregon's licensed healthcare workforce. An estimated total of more than 209,000 licensed providers and over 103,000 FTE of direct patient care are currently in Oregon. This table here shows the gender and race ethnicity breakdown for healthcare provider compare with Oregon's general population. Female providers are overrepresented in most professions, although men tend to be overrepresented in fields requiring more years of formal training, such as physicians and dentists. Latino providers are underrepresented in most healthcare professions. Next slide, please. So figures on this slide shows that Oregon's workforce is less racially and ethnically diverse than the general population. Spanish is the most common language spoken, other than English, among licensed providers. And less than 1% of the licensed healthcare providers are native speakers or have advanced proficiency in other languages. Many patients who speak a language other than English will need the assistance of a healthcare interpreter. Next slide, please. This report also included the area of unmet healthcare need data from the Oregon Office of Rural Health. The areas of unmet healthcare needs data includes community-level data on access to care and healthcare workforce capacity in 128 primary care service areas. This table here shows scores for unmet healthcare need by geographic area. Lower number indicate greater unmet need. From 2022 to 2024, rural and remote areas consistently have greater unmet healthcare need than urban areas in Oregon. Next slide, please. We received a feedback from Healthcare Workforce Committee in last meeting regarding integration of behavioral and oral health into the PCPCH program. We worked with OHA and subject matter experts to collect this data. A total of 33 current PCPCH, or 7%, have attested to the provision of oral health services by dental providers. A total of 383 current PCPCH, or 62%, have attested to provision of integrated behavioral health services, including population-based same-day consultations by behavioral health providers. Next slide, please. I will now pass to Veronica to report the recommendations.
Hi, thank you. Thank you, Tao. This is Veronica. And just before I go into the recommendations, I did want to update on our meeting yesterday with, we had an informational presentation to the Oregon Health Policy Board, and just a couple notes that they had about some refinements to the recommendations. They're not going to be showing here on these slides, but I just wanted to give you an update of what some of their suggestions were. They did overall like the recommendations. They want us to note the need for more prescribers to meet the need of the opioid use disorder and treatment services. A little more details on some of the housing initiatives for the healthcare workforce. And in the recommendations, they would like to have more community input in future iterations from rural and underrepresented groups. They would like to not only strengthen the pipeline, we mentioned, high school, but actually starting earlier, talking about jobs in the healthcare workforce in elementary school. In terms of data, They noticed that Latinos and Latinas are underrepresented across all the sectors, and really having some recommendations focused on understanding or assisting with increasing representation from the Latino and Latina populations. In terms of data, requesting that more measurable goals were set for workforce numbers and diversity. Requesting that when we start collecting data, that we have more data disaggregation on race and ethnicity, and that we include nativity and immigration variables, and that on the evaluation reports, as we see turnover or staff leaving, wanting to know where that staff goes to. Do they stay in the healthcare workforce, but in a different type of job, a different type of organization, or do they leave the workforce, the healthcare workforce altogether? And how might we get them back into the healthcare workforce? So those are just some nuances that we were going to integrate into some of our refinements into the recommendations. And I just wanted to give you that input as we start these next discussions. We have bucketed broad recommendations into 4 areas. And then as you'll have noticed in the report and on our next slides, we've taken each of these 4 broad recommendations and listed them as continuing recommendations. Those that we had listed 2 years ago in our report that we're making progress on, but still need to work on, and then some new recommendations. So the 4 recommendations are going to be first around funding. There's been a lot of funding in the last few years, and we're recommending to sustain funding levels to sustain the momentum. We haven't achieved everything that we'd like, but there has been a lot of progress. We again want to maintain progress in improving the diversity of our staff to provide culturally responsive care. Looking at multiple solutions to address the shortages of the workforce, especially in rural areas. And enhancing data collection, again, identifying not only the descriptions that we've just discussed, but also what's been working and what are some of the challenges and some of the programs and initiatives that we've been funded. Next slide, please. And so I'm not going to read over each of these slides, but just pause for a moment. Again, they're in your report because we want to make sure we have time for questions. But again, within the funding levels, maintaining and continuing the investment in some of the programs, the increases that have been seen in the salaries, then incentive programs as well. Next slide, please. Some of the new recommendations, some different strategies from some of the Medicaid programs that have been going on within our state and in other states to actually support the healthcare workforce. So for instance, additional payments for services to providers that serve OHP members, looking at new reimbursement models to support the true cost of providing services, including administrative costs that may go into it, increasing training slots and opportunities, focusing on supporting preceptors and teaching faculty. That seems to be a shortage or a stoppage of getting people trained. And then again, bonuses again for recruitment, especially in certain areas of the state, housing stipends, childcare, reflecting back on the social determinants of work. Next slide, please. And I'll go through each of these slides briefly, and that way, again, time for questions. So again, maintaining progress in improving the diversity of the workforce. Again, improving reaches to all areas of the state, all counties, focusing again on the health equity framework, and again, supporting and providing entry and support for those entering and in early career development and expanding into leadership opportunities. Next slide for the new recommendations. Some ideas about actually improving the diversity is really exploring the possibility of internationally educated healthcare professionals coming to Oregon. Investigating some of the licensure reciprocity agreements. So from other states, there has been some in some of the sectors. There's been some, again, strengths and weaknesses of doing that. So really evaluating whether that is, that should be explored in other sectors. And expanding community partners in certain community-based organizations, the work of them in mental health services, as well as other healthcare sectors, such as incorporating them into faith-based communities. We talk about recruiting and mentoring persons of color, but then including investing in networks and models and for affinity groups to maintain in the workforce and increase leadership pathways. Next slide, please. this is our, again, multi-pronged solutions to address the shortage. Many of these on here are our continuing recommendations, continuing and doing what we're doing on the training opportunities, supporting the pipeline. Here we mentioned middle and high schools, again, really thinking about what could we do in elementary schools, again, looking at new pathways. So some of the same strategies we had mentioned 2 years ago, but continuing to do those. Next slide, please. In terms of addressing the shortage, some new recommendations. Again, looking at opportunities for compensation and benefits on the social determinants of health, really looking at housing initiatives. And that's an issue we know from many sectors of the workforce. But again, looking at housing and childcare, support training for rural health and behavioral health providers on gender affirming care. So the gender affirming care was a new section in this year's report. Looking at new ways to improve wellness and resiliency in the healthcare workforce. Again, intentionally partner with K-12. There has been a lot of suggestions about this pipeline K-12, and there has been some work, but there hasn't been as much, we feel, intentional partnerships and funding and dedicating FTE to actually partnering with K-12, increasing remote work and telehealth opportunities. Next slide, please. Our last section is on data collection. Again, really looking at, and continuing data collection, but actually looking at ways to enhance it. So for the continued recommendations, they are continuing to do survey data collection, integrating REAL-D and SOGI variables, and looking at data collection plans for the healthcare employment section. Last slide, next slide, please. These are our continuing or new recommendations. Again, looking at the benefits, so evaluating some of these benefits of some of these programs, such as licensure reciprocity. Looking at new data collection on how well some of these benefits are attracting or retaining staff. And really looking at, again, the benefits and some of the unintended consequences maybe of some of these initiatives. So what we've heard is that perhaps with some of these initiatives, people are leaving certain sectors of the workforce to go work in others where there's stipends and benefits, and how does that balance out? Do they leave certain types of organizations because of the benefits or the funding opportunities at other types of organizations? So just looking at, again, the benefits and some of the unintended consequences of some of these initiatives. Next slide, please. I believe that's our last slide. Okay, so before we go to vote, and I will pass this back to the chairs, but we're open to questions, edits that you would like.
Thank you so much for that report. There's a lot of information in there. One thing that just myself noticed, I really appreciated the inclusion and the work around the strategy papers that were developed by the committee. So I am going to open it up for questions and comments by committee members. And Dr. Hemmings, I see that you have your hand up.
Yes, hello, good morning. Thank you. Thank you for that report.
We can't hear you, Dr. Hemmings.
Can't hear me.
Not very well.
Are you able to hear me now?
Yes, yes.
Okay, yes, my mic was up. Thank you for that report. My apologies that I was not able to attend the presentation to OHPB. Otherwise, I would have probably been able to share my comments there. So just really quickly, if you could go to, I believe for you here, it's page 20. I had a question about the threshold being 2.0%. How is that determined? Why the 2.0%? Because I noted that without that, there would be a lot more reds on the board, especially as it relates to Black African American.
Thank you very much for these questions. We will work with our content experts in healthcare workforce reporting program to address these questions.
Okay, so you don't know.
Yep.
Okay, why 2% was determined as a threshold.
Mhm.
Okay. The other thing that I wanted to zoom in on is the social work numbers. what's the period of this data collection here? What period is this? What year? Year two? Was just
Uh,
for the year of 2020. Was it done in 2024? What period does it cover?
I think this table here is data as of January 2024.
Okay, the reason why I asked that because it was interesting to me to note that
Mhm.
for the social work numbers, looking at the Black and Latino as well, numbers at 6.1% for Blacks, 13.7% for Latino for the CSWA, and then 2.4% for LCSW for Blacks and 4.9%. Significant difference. I mean, I'm wondering how much of the OHA healthcare behavioral health workforce grant is contributing to that CSWA number. And I'd like to say, I think that's a really great program. Definitely should be continued. And the reason why I want to know the period of time because of when the grant was actually first implemented, was focused on increasing cultural and diverse and linguistic providers in behavioral health. So I'm wondering if that number contributed to the huge number actually for CSWAs for Black and Latinos. The other thing I'd like to look at is moving forward to see how many of that 6.1%, 13.7% actually translates into actual increases in LCSWs, right? And for us to take a look at what are the barriers that exist from moving from a CSWA to an LCSW. And I can tell you from my experience in doing clinical supervision, one of the barriers is the fact that the board exam is very biased. And the state board needs to probably consider alternative to licensure for the social work population. The other question that I had related to oral health here for dentists. I noticed that you didn't have dental assistants on there. Was there a reason why they were left out? Was there any data collected for dental assistants? I see dentists and dental hygienists. My next comment is on the next page.
Can I just make a comment really quick? Dr.
Yeah.
Hemming, so sorry. I would just say that thank you so much for Andy Davis has put it in chat. In the next presentation, they're going to go more detailed into some of this data. And Andy Davis has offered to have you ask your questions about the 2% and some of these questions in the next section that and when they report in the next section of today's meeting.
Okay, so I'll hold off on my question
Thank you so much. And thank you, Andy.
Okay, I'll hold my question about how it's behaved. The next page, which is 21 here, the next page, which is I was going to ask when it says behavioral health providers, who's included in that? And then my next comment, which I guess is more aligned with this committee, is we keep talking about, I think there's two things that, Veronica, you mentioned about providing training around cultural linguistic specific care, right? And I'm just wondering, in terms of this committee, if that's something we really need to focus on. So there's a twofold issue here. There is one, which is increasing the number of providers, healthcare providers, who are more representative of the population, right? And then there's another component, which is having healthcare providers who are culturally and linguistically trained to provide services to people who may not look like them or share similar cultural backgrounds. Because as a provider myself, it's impossible for me to think that I am going to be able to actually provide the care to the entire Black population in the state of Oregon who's seeking for a provider who looks like them, right? So some way to offset that is to make sure that as a healthcare workforce that we have providers, all of our providers actually are able to provide and have the training that they need to provide cultural and linguistic specific care. So I think that's something that we probably need to focus on in addition to increasing the actual number of providers that represent the demographics in the state.
We can make those refinements to separate those out to maybe just make them more impactful that they're separate.
Okay. And then when we look at oral health providers and primary care providers, we know that OHSU is the only dental school in the state of Oregon and the only medical school in the state of Oregon except for naturopath, right? So when we look at these numbers, we need to probably take a look at what's happening there on a university level, right, in terms of who's going into the profession, what is being done. And you talk about pipeline programs. How is OHSU working with middle schoolers in terms of pipeline programs to help address some of these numbers here that I think is, problematic and not representative of the population, and whether or not they're including cultural and linguistic training to their students as well. So my other comments I will hold off because they're more statistics related questions. Thank you.
Sorry, I could not get off mute. Thank you, Dr. Hemmings, for your comments and questions. Ian, I see you have your hand up.
Okay, thanks, Laura. So you've mentioned a number of times the focus on moving the pathways programs down to K through 12 and whatnot. Have we looked at in either K through 12 or in the middle school and high school level programs, have we looked at the barriers to education in those? It's one thing to tell people that things are available, but when the general conversation is and dot dot dot, then it doesn't let us target specific programs. So I'm wondering if that data is available, first off, or something that we can get into the report where we can see where those barriers are so that we can incentivize behavior. That's my question.
I'll start and then Tao or Jeff, if you want to join in. So just to clarify, I think there's a couple questions within there. One is the barriers of completing high school and college for many of these degrees in general, and that has not really been addressed. So it's separate from healthcare specific settings. And what I wonder is on the barriers, is it barriers to the students participating, or what we've also heard is barriers of not enough time of our healthcare workforce to go and actually go to these schools. And I don't know if that means, and I'll be honest, I don't have an answer, but I think that might be both sides. As one is the barriers of getting people to go to some of the schools and spend time on a mentorship program or even presenting. Or are there other barriers to like completing the education pathway, Ian, that you might be referring to?
Yeah, well, Veronica, I've worked with a number of different groups where I've heard things like, yes, that would be great to have our kid, our son or daughter be a doctor or a son or be X, and then people scoping their expectations down to their perceived or actual circumstance. And so some of this is we're adding a lot of grant programs, the how-to grants and whatnot, but sometimes the community perception is different than the present. And how are we looking at those? Am I making sense?
Yeah, so when we go and do these presentations or this work, really then focusing about the journey it takes to get there. And really, okay. I'll see if others have, and there's also some comments in chat that we'll make sure to capture. Tao or Jeff, did you want to comment on that?
Yeah, I think this is a very good point. I think that also fits our recommendation that we need to we recommend intentionally partnering with the K-12, and also we have recommendations that to provide incentives or support for academic precision faculties, so that they can be provided enough FTE to support this K-12 education pipeline and career pathways. And we can definitely add a recommendations to collect more data to better understand the barriers to this issue.
Thank you.
Thank you very much, Ian.
Thank you for that. Dr. Chaudhry?
Hi, good morning, everyone. I'm driving right now and I'm kind of toggling, and please pardon me if this has already been reviewed and kind of makes me sound like a doofus. Um, I was wondering if there's been any demonstrated evidence of the increase in the number of behavioral health providers. The rationale and context for the ask is back in early 2023, the state invested in the behavioral health directed payment program in an effort to increase the number of behavioral health providers. And I'm curious if the data demonstrates, when reviewing 24 data, if we have had and experienced an increase in that healthcare provider.
May I address that? Thank you so much for that question. There has been an increase documented in the licensed workforce. So there has been provided to us from, again, the licensed workforce supply report, a 19% increase in behavioral health licenses between 2022 and since 2022. So in the licensure area, there has been increased, let me say this, we are now reporting on the certified workforce that doesn't necessarily, may or may not have a license. They've only just been beginning, so I would say that we don't have enough data to document that this really has increased the same way we have with the licensure, but we're hoping to be able to track that more through some of the reporting that OHA is doing on the certified workforce. What we also don't have quite yet, and we're trying to see if we can get that, is there an increase in the dual certificate? So people who are licensed and certified. That was a request that came from us, is, for instance, RN and also QMHP. So I would say we are definitely seeing it in the licensure area, and we are tracking the certified and trying to get more data on those. I would say what we still need more support for is the reach. So really looking at all counties. So we do see discrepancies between counties and again in providers of color. Does that, Dr. Chaudhry, that was a great question. Do you have a follow-up question for us?
Yes, I have a follow-up question. Thank you so much for sharing that this is something that you're already actively tracking. The follow-up question that I have is that while we've seen, as you shared, an experience, a 19% increase in 23 over 22, is there a cascaded increase for those that take care of our OHP population?
Okay.
Does that also go up by
Yes.
19%?
Okay, so I am gonna say, okay, let me just get to my notes here. I apologize. I don't have the top of my head, but I believe that a recent evaluation that came out showed that almost 50% of providers were not accepting OHP. In the last few months, there has been incentives to actually increase pay for those that do. And I believe, I'm hoping that I can include that in, I don't have those specific numbers off the top of my head, but I don't have the numbers of, have that increased OHP providers. In fact, I think that in itself has not, but that the pay differentials will have to be added to actually see increases in behavioral health providers serving OHP patients. Does that get close to answering your question?
Okay. Yeah, and reflectively, I find that disconcerting that we haven't seen a bump for OHP providers with this program. But thank you.
And if I am wrong on that, if others would please correct me. And if others on the call have expertise on the OHP provider side.
Oh, I don't remember those numbers.
Okay.
Yep. Is there a follow-up question from?
Well, I don't think so. Molly, did you have a question? Molly?
Yeah, thank you so much, Laura. Hi, everybody. I'm a brand new appointee to the committees, and I just have a quick follow-up question in regards to home care workers and personal support workers, sort of those folks who are in the entry level healthcare fields. And if we've done any research or anything has been explored as far as career pathways for those folks to kind of move up in the care fields, and as far as stackable types of credentialing, using previous experience in home care work or personal support work to qualify as experience in higher level in other aspects of the of the care fields, if that makes sense. Thank you.
So I can talk about that briefly. In the long-term care section, we talk about things like, and in the long-term care section and the appendix, we talk about, for example, the RISE partnership that helps people who want to become CNAs actually get their training and have stipends and other support during that period. And there's also a smaller effort, which is encouraged to be expanded, that would allow people who are CNAs then to become LPNs as well, and potentially a pathway to registered nurse. So those are programs that are, especially the RISE partnership, currently funded, but we talk in the report about the recommendation to expand those to a larger number of potential participants.
And I know, thank you for that, Molly. I know Dr. Hemmings had a couple of follow-up questions. I'm not sure if those we should answer those here or in Andy's presentation, what would be most appropriate?
I don't know if you're asking me, but I thought they're probably more appropriate for Andy, as it's more about the mythology of, and definitions of the terms being used.
Okay, perfect.
Thank
I just
you.
did not want to not address it, Dr. Hemming.
And if, this is Veronica, if I could update a quote. When Dr. Chandra asked me questions about I was ready for oral health questions. And so I provided numbers from my oral health section, not the behavioral health. About half of oral health providers are not accepting OHP patients. I don't have that number on the behavioral health side, but I will look into that, and we'll note that we need to track more if we see an increase in the behavioral health services to OHP members. So apologies, I just mixed up some data points that I was sharing with him.
Thanks, Veronica.
Thank you, Veronica, for preempting any oral health questions that I may have. So appreciate it. Sorry, I just want to acknowledge that.
No, I was ready for oral health questions and just didn't respond correctly. So apologies.
Yeah, sorry, I'll do better next time. I'll make sure I ask more oral health questions.
Elena, I saw you had your hand up, and then Surya, will go to you.
Sure. Yeah. Just to follow up to that comment, Veronica, I'm a dentist too. Hi.
Thank you.
I know that before the statistic has also been shared that about 12% of dentists in Oregon accept OHP. So is that half number that of those 12% of dentists, only half are accepting new patients, or have those numbers changed?
Do you know what? Let me double check. I will need to clarify that. What is my denominator? And I believe that it's half of Oregon. I need to double check, but I don't believe it's half of the 12%. I believe it's half of Oregon, but I would like to double check that report that I'm pulling that from, and I can clarify that in the report.
And for what Dr. Shabosky has indicated at the House committee back in May, Chelsea Guest presented that 12% of the dentists in the state of Oregon perform the majority of all of the care for 34% of Oregon, and the 34% is equating to OHP members. So,
thank you.
But that, I mean, I'm just sharing that we can compare against that, and that was what Dr. Shabosky is referencing contextually.
Okay. Thank you. I'll double check that and pull that into the report just to clarify.
Thank you.
Surya, if you could introduce yourself for us and then go ahead and ask your question.
Uh, yeah, thanks. This is Surya Karlapati. I'm a psychiatrist at the Oregon State Hospital. I'm one of the new members, and I think we are planning to have a more formal introduction in January. So I'll keep more uh, information related to that in January. But again, this is my first time attending this meeting, so I'm sorry if I'm being repetitive. I'm trying to piece all the, I mean, connect all the pieces and understand the the broader perspective of this. My only question is, how much of these resources are being invested in collaborating with schools in expanding the class size or even adding uh, new uh, new classes or new training institutions so we can address the shortage in numbers in terms of numbers. Thanks.
Yes, we do have some recommendations and some examples on expanding the training slots and, like, for example, increasing the numbers of residency trainings in order to support the development of to expand the workforce in our report.
Uh, have
Yeah,
there
but,
been any increase in numbers? Sorry.
For example, let me see the. I'm checking my report here. So what's your specific questions?
Just any increase in the class size numbers, and it could be any licensure or certification related courses.
We do not have the exact number of the increasing the number of classes. We do not have that data. Regarding that. Yeah, but
And that was my question, like,
yeah.
are there resources allocated to expanding the class sizes that's graduating or the incoming classes so we can add to the numbers, and we can start working on building new classes and focus on the diversity of the intake class and addressing the barriers of because I see there is an emphasis on awareness early, starting from K to 12, and then a lot of loan repayments and incentives and stuff. But what about like the actual expanding the class sizes or even starting new training institutions to address our own in-state healthcare needs?
Yeah, we do not have that number in this report. Veronica, do you remember that number or?
I don't, but I think there's comments in the chat. And what we could do is Dr. Hemmings mentioned that they've decreased their class size. We could add a note about reaching out to our current existing healthcare workforce training programs. Are they able to actually increase enrollment numbers, class size, cohort sizes? And what would they need to do that? And then somebody else said OHSU is stable. So I don't actually know, but I think we could add that note in about exploring with those institutions, what would they need to expand their capacity to educate? Okay.
Yeah. Can we link that to our new recommendations? Because one of the new recommendations we mentioned here is to collect data to evaluate the consequences of or the outcomes of those incentives and funding programs.
Thank you.
Yeah, thank you very much.
Thank you, Tal.
Yeah, and I also want to have a follow-up comments that we discussed some examples in our report. For example, there was some House Bill. One example is the House Bill 3261 is to support increasing the to support apprenticeships and on-the-job training for the healthcare workforce. Yeah.
Right. Eric, go ahead. And if you just introduce yourself quickly, Eric, we might have all these introductions done for the January meeting.
Yeah, hi, my name is Eric Weiser. I'm a family physician, but also serve as role as the interim director of the Oregon AHAC for the last 5 years. And I'm also the assistant dean of the rural undergraduate medical education at the School of Medicine. So I just have one comment and then a couple kind of observational questions. The first comment is that really nationally, we've moved to the phrase pathway instead of pipeline. And that was done really in a couple of reasons. One is to really acknowledge to our Native American colleagues that pipelines through have a negative connotation, especially if it's bringing fossil fuels through lands. And lastly is that a lot of people's entry into healthcare isn't linear like a pipe, but more wandering like a path. So with your report, it's a national recommendation to move towards the word pathway, and I recommend adopting that language. The next piece is more of an observational thing. It looks like two of your recommendations might, I don't know, from at least first glance, appear to be contradictory. And there's two contradictory recommendations. One is that, the increased risk or access to international grads, but you want specific diversity in our current workforce. And I'm not quite sure if those two line up. And then the next contradiction I want you just to comment on too is just, increasing mental health in faith-based organizations, and not all faith-based organizations support gender affirming pathway or gender affirming care too. So I was just wanted to let you comment on those two pairs of recommendations.
Jeff, do you want to respond to the gender affirming care first?
I'm sorry, which pair of recommendations was that, Dr. Weiser?
So the first one that, there was a recommendation to, use some faith-based organizations to increase access to mental health. And I'm just wanting to make the comment that like not all faith-based organizations support gender affirming care. And then all the work that you guys are doing about gender affirming care. I'm just like curious on how you may address that pair of guidelines.
I think that's a good question. We can go back and look at that. I see your point that not all faith-based organizations will support gender affirming care, but it's very important in the mental health space. So
I'll just add, I think that the faith-based care got brought up with some of the reports that are coming from other organizations about the trust and bias within the healthcare system, and really wanting people from the community to provide some of these services as a way of access, at least to get to that community. I do see your point that it could be contradictory. And I just wonder if we need to just specify that, but actually still keep moving forward in both directions. I mean, I think I don't have an answer. Yeah, I would just, I think both areas are needed. And I think that the gender affirming care is definitely a new area. And I would like to come back to your other question too. The contradiction between increasing international students and the increasing in diversity.
Just, like some of the diversity specifically we need is African Americans and Latino, but that's not necessarily where we bring in international grads from.
I see what you're saying. Okay. So I think we could, I think because there is such shortage in such areas, that still looking at both recommendations, but maybe we can add some refinement on the international one about that would actually support increasing the diversity on those pieces. I think there's still the want to increase those that come from Oregon to stay in Oregon, but I don't think we're just going to have those numbers. So how to expand that, but maybe we could add some nuanced data there.
Yeah.
I don't know if Tao or Jeff.
Yeah, and actually in our report, we share an example out of state. For example, in the University of California, UCLA, they have international medical graduate programs that's specifically for Spanish-speaking international medical graduates to not only support their development of healthcare workforce, but also diversify their workforce, specifically for Spanish speaking IMGs. So that is one example that we share in the report.
And Dr. Weiser, I think what we can definitely replace the language to pathway from pipeline.
Yes.
Thank you.
Yeah, I think separating that from shortage versus diversity will be helpful. bringing the staff to address the shortage of healthcare workforce is one thing versus using the same numbers to enhance diversity is a different thing. So because diversity is a good thing, but if you lack the cultural competence, it will be a harder thing to serve the native population. So maybe separating those two will be helpful. Thank you.
Yeah. And I also want to clarify that the section title in our report is called Education and Career Pathway.
Perfect. Ian, before we get to your question, I know Dr. Hemmings, you had your hand up, but then took it down, but I just wanted to see if you still had a question.
I don't remember what it was I was gonna say. Thank you.
Okay. Okay.
Oh, I know what it was. I was gonna ask Dr. Carla. I don't want to. I'm saying the name incorrectly.
Carla Patti.
Carla
You can just call
Patti.
me Surya.
Yeah, Dr. Surya. When you asked your question about increase in admissions, or increase in, I was wondering if you were also referring to in terms of programs that were not necessarily at the university college level, but within middle schools and high schools as well.
No, I'm more referring to more not at school level, definitely.
Okay. All right.
Thank you.
Okay, we will go ahead and Ian, we'll let you have the last question. We're a little bit over time, then we'll take a quick break before we get into our next presentation.
Okay, thank you. So just a question, when you're looking at faith-based programs, are you really, is that more of a specific instance of culturally relevant care, or is that something different? You know, like looking at broadening our, you know, faith-based for patients with a faith-based scope, or is it something different?
It came up in reports around culturally responsive care, and that faith-based communities may be a way to reach communities that don't want to access traditional healthcare settings for one reason or another, and that the faith-based may be a way to expand culturally relevant care. That was the part that it came up in that instant.
Got it. Yeah, all right. Because I think that is important that people, you know, as we talk about people being able to see people who look like them, quote unquote, faith-based simply becomes one of those groups. All right, thank you.
Perfect. Okay. Before we go to break, we are tasked at this meeting with approving this report today, this healthcare workforce needs assessment. And so I will entertain a motion to approve the 2025 healthcare workforce needs assessment. I can't see hands up, so if someone is making a motion or wants to make a motion, and this by approving this today, then it will go to the Oregon Health Policy Board for their January 7th meeting.
Laura, I'm not seeing any comments because I mean, I'm wondering if there's some hesitation because the questions that were asked.
Right.
There were some pretty significant questions.
Thank you for saying that. I was thinking that to myself, or are we voting when we still haven't really heard?
Yeah, so I think there might be some hesitation.
Yeah, I thought about that. So Neelam, I'm gonna just kind of turn to you and Deepti and ask if this, if this does not get approved today, is it possible to have questions answered by email and do an email vote? Since it's not, if we don't approve it today, I'm not sure we will get it to the Health Policy Board unless we do an alternative type of.
Yeah, This is a legislatively mandated report that we are required to deliver to the Oregon legislature by February 1st of odd numbered years. So, and the only time that OHPB is meeting before that deadline is January 7th. And given
Yes,
the
we want
holidays, yeah. Mhm.
clarify adding in. I mean, I think we've been taking notes about changes that we can make, and about the phrasing, about the data points to add in, about separating some of the recommendations, the refinements of the recommendations. And I don't know if it's be possible.
Yeah, and we can clarify some questions with our content experts in the healthcare workforce reporting data program.
So Elena asked in the chat if it would be possible to make the proposed changes and vote via email before January 7th. Is that something that we can do, Neelam? Oh, Dr. Hemmings, I see you have your hand up. I'm sorry.
Yes, as far as I'm concerned, it doesn't matter to me if my questions get answered today because I'll have an opportunity to review it again when it comes to the board. So don't, hold up a vote on my count. If other people are fine with passing this the way it is, I'm okay with that because I have another opportunity to address my concerns.
Could I also say we could make edits that were taken today into the next revision?
So then I guess the question is, can this be approved by email vote, Neelam?
Yeah, I think we would have to huddle afterwards and figure out that timeline because we do need to send the approved report to the Oregon Health Policy Board at least a week in advance. So, it's possible. It would just be a tight timeline given the holidays.
Right. Okay, so committee members, is that what we prefer to do, is see the revised document with the changes and then do email vote?
I feel good about that. I'm curious from Dr. Weiser and Dr. Carlopati if you both had. I know Dr. Hemmings spoke up. Do you two feel comfortable with that?
I mean, we can even approve it today. As long as we capture in the minutes the questions being asked and the recommendations made, if we can capture those in the minutes and make those recommendations as recommendations, and we can actually vote today. I'm fine with that.
Would committee members be okay with that? And just a reminder, the new committee members can't vote on this today, just because you can't start voting until the January. But current committee members, would that be acceptable if we went ahead and did a vote on this today to approve it with the changes that are captured in the minutes from the recording being made?
This is Manu, and I feel that an email approval would be more appropriate, similar to, or kind of in line with what Dr. Shabalowski and Dr. Hemmings had kind of alluded to.
Okay. All right. And I'll just preface that with saying that sometimes we don't get a ton of responses to emails. So if we have to have a quorum to approve this, so if we put this out for an email vote, I'm just going to need everyone to be diligent about responding. And if not, I'll come and find you and get your vote. Okay, so I will just, for the record, we will have the folks from Oregon State University make the proposed changes, send that out to send it to us, we'll get it to the committee, for review. And we'll have to have a vote, probably by December 20th. If that's, I don't know if hopefully that's possible to get the changes made by then. We'll send it out. We'll need a vote pretty quickly. Neelam?
Yeah, I was going to ask Oregon State, when they think we can get the report, the next version.
We will start working, and we will continue working with OHA and our content experts to address all these questions, and we will add those recommendations and edits in our report. So I cannot say a timeline now because I will see, how soon we can get those data.
Do you think within a week, Tao?
Yes, we can. Yeah, we can do that.
Okay. If we could get the document back in a week, we can get it out for an email vote. And like I said, committee members will just have to be very diligent about responding to the email.
Yeah, so when then would the vote deadline be if we send it out by the 18th?
Yes, if we can get it back by the 18th, we'd have to have it back by the 20th, which is only 2 days. So that's why I'm saying it's going to be a really tight turnaround.
Yeah, and what if we don't hear back? Then what is our
Then I will personally call everyone and say, what is your vote? And record it and email it to me so we have it for the record. I don't want to say I'll hunt you down, but I will come and find you and I will get your vote. Whether it be
I have a possible suggestion. I'm not exactly sure what the appropriate terminology is this, but what if we set a vote right now that we would approve the revision, or if the revision isn't approved by the whole committee by the 20th, then it will automatically move forward as the final version. And I think that would save a lot of time on your end, Laura, and then also a potential consternation of not having a completed document by then.
Neelam, what do you think? I think Dr. Chaudhary, I think I'm okay with doing an email vote, really. I mean, I would like to see the revised document. If they can get it back to us within a week, we'll get it emailed out immediately. And I'll let everyone know that the document's coming. But I would be okay with that, Dr. Chaudhary. I'll make it happen. And I just think for everyone to be comfortable, they might just want to see the revisions in the document.
Sure. I wonder if we could say if we don't hear from people, we'll take it as approval, because we do need to get the report approved by the 20th, so it could then go to the Oregon Health Policy Board for their approval.
Yeah. Okay, let's go that route. We'll get the revisions back and then we'll send it out for an email vote, with the understanding this is a very tight turnaround. Okay. I think we are at our break time now. Let's just take maybe 5 minutes. We'll come back a couple minutes after 11. Is that all right, Neelam? And then we'll get right into our. Okay. All right. We'll take about a 5-minute break. Feel free to turn cameras off while you're on break, and we'll see everyone. If you are back from break, if you could just turn your cameras on so we know how many folks are here. Great. Okay, I think we'll go ahead and get started. Jessica, if you could go to the next screen, please. Perfect. Okay, so we are going to have a presentation on our the report on the diversity of Oregon's licensed healthcare workforce. And I will turn it over to, I'm not sure who's leading that discussion for us today.
I'll get us started. Piper.
Oh, Piper. Okay, hi, Piper. Thank you.
Hi. Great. Well, I will kick us off. So I am Dr. Piper Block. I use she, her pronouns. I'm going to start us off with this presentation on the diversity of Oregon's licensed healthcare workforce. So this is very much aligned with some of the findings in the last presentation. We use a lot of the same data and really looking forward to continuing the rich discussion. I'm really excited to hear so much engagement and questions. So I will just get us started. Going to the next slide, please. Just situating our program within the wider context of the state. So the program that is collecting and analyzing this data, we're the Healthcare Workforce Reporting Program. That team sits within my management structure with the Research and Data Unit. We're within the Office of Health Analytics and the Division of Health Policy Analytics. And just to be clear, this is a very abbreviated org structure just to kind of show you where we're at. We also work closely with the Healthcare Workforce Initiatives team, who is staffing this meeting. And then in the purple, we have our close partners. We work very closely with the health licensing boards, both to collect survey data and make meaning of it. And then also with you all, the Healthcare Workforce Committee and the Oregon Health Policy Board. Next slide, please. So the program has existed since 2009. There were several boards that have been reporting since then, and then we added additional boards in 2016. Now we have 17 boards that license 37 individual health occupations, which account for over 200,000 licensed healthcare professionals in Oregon. And now I will hand it to my colleague, Dr. Meredith Halling.
Piper. Hi, everyone. My name is Meredith Halling. My pronouns are she, her. I'm a research analyst with the Healthcare Workforce Reporting Program. And I am going to give an overview of the Healthcare Workforce Reporting Program's data collection process and then get into some of the findings from the 2024 diversity report. If we could go to the next slide, please. Thank you. So Healthcare Workforce Reporting Program data is collected from the licensees of all of the boards that were just showed on the previous slide. A question came up earlier about why dental assistants are not included, and that is because they aren't licensed by the Oregon Board of Dentistry. They're certified by a different body. And so that's an important limitation to Healthcare Workforce Reporting Program data. Just that there are many healthcare occupations that provide critical care to Oregonians, folks like qualified mental health associates, certified recovery mentors, peers, traditional health workers, medical laboratory scientists, all members of the healthcare workforce, but that are not covered by the Healthcare Workforce Reporting Program and are not reflected in the data here. So Healthcare Workforce Reporting Program data is collected using an online survey that's completed as a part of the license renewal process. The information is collected and then processed and analyzed by OHA and put to use in products like reports and dashboards. And because the data collection is linked to the license renewal process, there's a couple of limitations to be aware of around that. First is the timing. So new data from an individual is collected every 1 or 2 years, depending on the board's renewal cycle. And then another consideration is that because the survey is done as a part of the license renewal process and not initial licensing, first-time licensees don't take the survey. And so we do not have data from that segment of the licensed workforce. Next slide. Could we make the presentation full screen again? Would that be possible? Thank you so much. I'll just keep kind of talking. So the Healthcare Workforce Reporting Program database contains a lot of information. Thank you so much, Jessica. And the data collected by the survey can be organized into these three main categories. So if we have demographics, overall practice patterns and characteristics, and then the survey also collects location-specific information, so like work address and hours, future plans. It's noted here on this slide that the demographic data collection includes REAL-D. Can we go to the next slide? And I'll give a little bit more information for those that might not be familiar with that. REAL-D stands for Race, Ethnicity, Language, and Disability. And it refers to the data collection standards that are required for the Oregon Department of Human Services, as well as the Oregon Health Authority. So among other things, it offers expanded, more disaggregated race and ethnicity options. So the Healthcare Workforce Reporting Program implemented REAL-D data collection in January of 2021. In this report, we present both parent group race and ethnicity data, as well as more granular REAL-D like subcategory data, and that the relationship between those two is shown just for the Asian parent group in this little table on the slide. The full REAL-D categories are available in the appendix of the report, the draft report, which is part of the meeting packet. And this is the first diversity report from the Healthcare Workforce Reporting Program where REAL-D is available for the entire workforce because of renewal cycles and things like that. So we are excited about that. Could we go to the next slide? So with that background, I'll move into some of the data that is presented in the diversity report. I will take a second to talk about the data set itself. So as a reminder, the survey is part of the license renewal process and taken by the entire population of professionals who are renewing a license. And as noted here, the data that was analyzed for this report was collected between January 2022 and January 2024. I'll also note that while the survey in general is a required kind of part of the licensure renewal process, but answering the REAL-D question set is not. Folks are allowed to move through the survey and not answer those if they do not want to. And 12% of the licensed workforce declined to provide race and ethnicity data. So we wanted to note that. Next slide, please. So first of all, so looking at the licensed healthcare workforce as one whole group, we see that at the parent race and ethnicity group level, Asian and white providers are overrepresented in the licensed healthcare workforce compared to the Oregon population, with the workforce being shown with the purple bars, the Oregon population is in the orange bars. However, if we go to the next slide. So while we see Asian and white professionals being overrepresented at the parent group level, there are a couple exceptions that we see when disaggregating and analyzing race and ethnicity using the REAL-D subcategories. So a few examples of this. So for instance, healthcare workers who are members of the communities of Myanmar are underrepresented. So at only 0.01% of the workforce versus 0.1% of Oregon's population. While the rest of the Asian subcategory race and ethnicity groups are either overrepresented in the workforce or present at about equal proportions. And then in the white parent group, which is in the box over to the side, healthcare workers who identify as Eastern European, Western European, and other white are all overrepresented compared to Oregon's population, while Slavic individuals are underrepresented. They make up 1.8% of the workforce, but 3.7% of the state population. And if we could go to the next slide. So this is the second half of that chart that started on the previous slide. So here we see that Hispanic and Latinx licensed healthcare workers overall are underrepresented compared to the Oregon population. And this is especially exaggerated for Mexican healthcare professionals. Mexican individuals make up 3.4% of the workforce, but are 10.1% of the state population. So these are the trends that we see when looking at the licensed healthcare workforce as a whole. But of course, different occupations have different dynamics and different barriers. And so we also present information in the report broken out by individual occupations. Could we go to the next slide? So this is a chart that we've seen before today. So it's, I'll show this same chart over the next few slides. but this is showing race and ethnicity as well as gender for all the licensed healthcare occupations. The state proportions are shown in the top in gray, and then the boxes are color coded in comparison to the state. And this color coding system is based on this 2% difference, which came up earlier. And I will say in previous reports, we used 0.5%, and changing that was more of a visualization choice to highlight areas with bigger differences. But that said, we appreciate the concern being brought up and for checking us on that because we really do not want to underplay gaps that exist. So if as a committee you'd recommend that we change that threshold for the visualization in the report to a smaller margin, maybe back to 0.5%, we would be happy to incorporate that feedback. And I think Andy will talk more about this later in the presentation and has some options here as well. But to kind of keep going through this a little bit. So also I will note the race and ethnicity data presented in this chart is at the parent group level. And the report also includes a large appendix that shows race and ethnicity composition at the disaggregated real D level for all of the occupations. So here we're looking at, we also have gender data on this chart on the far right side. The Healthcare Workforce Reporting Program survey currently has one question about gender, and the response options are female, male, prefer to self-describe, and then decline to answer. So we had about 2% who declined to answer, and then 0.6% self-described. And there is more information in the report about that, and we can put that information in chat too, about those folks who choose to self-describe. But I just wanted to acknowledge that we are only presenting male and female here, and that is leaving out a segment of the workforce. Looking at only these two gender options, male and female, there are just 4 licensed occupations where men are overrepresented compared to the Oregon population. And those are kind of outlined in the chart with the black boxes. Chiropractors at 62.5%, dentists at 65.7%, physicians 57.8%, and podiatrists at 78.2%. So all professions with higher barriers to entry and higher potential income levels. Could we go to the next slide? Another trend to call out here is that Hispanic and Latinx professionals are overrepresented among 2 occupations. So chiropractic assistants, 17.3% compared to 12% of the state, was shown in the square that is outlined by the black box at the top of the column. And then certified nursing assistants, so 18.2% farther down in that same column. But there's Hispanic and Latinx professionals are underrepresented in nearly all other occupations. And this is at the parent group level. When we look at the disaggregated race and ethnicity data, that the overrepresentation of Hispanic and Latinx chiropractic assistants is driven by professionals who identify as either Mexican or other Hispanic or Latinx, while the overrepresentation among CNAs is driven by folks who identify as other Hispanic or Latinx. Can we go to the next slide? This is fine. This is just the second half of the chart. Another thing to note here is that the Asian professionals are overrepresented at the parent group level compared to the state in several occupations, but both on this slide and the last, those overrepresentations are not seen across all of the Real D race and ethnicity subcategories. So for instance, for pharmacists, looking at the Real D breakdown for that occupation shows that Asian overrepresentation at the parent level is driven by Vietnamese, Chinese, Japanese, and Korean pharmacists for that occupation. So the Real D level race and ethnicity breakdowns for all the occupations are included in the report. And that draft report, like I mentioned, it is a part of the meeting packet. So I would encourage you to look at that. It's a really rich source of detailed information. And with that, I will hand it over to my colleague Andy to present more of our findings.
Thank you, Meredith. We can go to the next slide. So my name is Andy Davis. I'm also a research analyst with the Healthcare Workforce Reporting Program. Nice to see you all today. I might, before I start on this section, Laura or Deepti, could I get sort of a time check? Because I know that we started a little late and I wanted to know when you wanted us to wrap up.
I do not have the agenda in front of me. Do you know?
I do, Laura. Yeah, we originally had about 10 minutes for this topic left, but I think we can, since we don't have too many people signed up for public comment, I think we can extend your time and give you maybe 15 to 20 minutes.
Okay, thank you, Deepti. I'll try to be quick through these slides, especially because this one and I think the next slide you've seen from the needs assessment. So we break things down within the report by clinical focus area, formerly known as specialty groups or specialty areas. We've changed that nomenclature from feedback from the boards, not wanting to conflate things with specialties and certification. But we look at primary care, behavioral health, and oral health workforces. I think Dr. Hemmings may have asked a question earlier about behavioral health and who is part of that group makeup. That's essentially so part of that is driven entirely by the license types. So there are like counselors, psychologists, social workers who are in that group by default. There are also a variety of professions, naturopaths, nurses, physicians, who, based on what they report their area of practice to be, so we ask a question in the survey about what kind of practice you are undertaking. And if they report that they're doing child psychiatry or something like that, then they will be put in the behavioral health clinical focus area within the report. Hopefully that answers the question. I'm happy to go into more detail if you'd like. But we do see overrepresentation for Asian and white providers broadly in primary care, Asian providers in oral health, and then in behavioral health, almost all categories of people of color are underrepresented. So the white category is overrepresented in that group. We can go to next slide. And again, you've seen this from the needs assessment today, but roughly 20% of our workforce reports speaking a language other than English. About half of that part of the workforce, so 9%-ish of our workforce uses their second language in their professional practice. The vast majority of that segment is Spanish speakers. There are some impacts from Chinese, Vietnamese, and Russian speakers within the workforce, but most of this is Spanish-speaking bilingual folks. Next slide, please. We do cover in the report the disability section of REAL-D, and what I would broadly say, and I'm going to sort of gloss over this slide right here, is that so cumulatively in the state of Oregon, if you look at all of these parallel disability questions to what we've got in our survey, and you take a additive approach to it, so any disability is counted for someone, there's about 15% of the Oregon population reports having one disability. In our workforce survey, we see about 2.6% additively of folks who are reporting at least one disability. It is much lower than the Oregon population. I will give the huge glaring caveat that the Oregon Medical Board does not collect these disability questions on their version of the survey. They administer the survey on their own, and they've chosen not to collect these particular questions. So especially in the area of primary care, and this is noted in the report, especially in the area of primary care, I would expect this not to be I couldn't guarantee that this is an accurate number for that clinical focus area because it does not include physicians or the other professions who are part of their Oregon Medical Board. Can we go to the next slide, please? So these two slides I'm going to take a couple of minutes on because I want to make sure that they're sort of understood. So one of the things that we wanted to look at is the changing diversity of our workforce over time in this race ethnicity aspect. We have some challenges because of the change to Real D that we can't just look at trend line data for particular race or ethnicity categories because there's a big discontinuity when we look at the old segments, the OMB classifications versus the new Real D. There is a chart in the appendix or in the methodology section of the report that looks at it in that way, and you can see some things like Dr. Hemmings, I think it was you that asked about using rarest race and multi-race and how things are recategorized. There is a chart that shows some of that discontinuity, and there are some results like a drop in the Latino, Hispanic Latino category because of that recategorization, frankly. And so we tried to come up with a way to look at trends or to look at future forecasting that didn't depend on that trend line data. And this is sort of the result. We're looking at folks in age categories to see how our workforce may develop in the future. We've separated folks into buckets by age, so under 30, 30 to 39, 40 to 49, etc. And we're showing the group level race and ethnicity categories. We've separated white off to the side because those bars would be dwarfing the other bars if we put them all in the same chart together. But one of the takeaways here is that if you look at the younger cohorts in that series of white bars, they are much lower than they are in the older cohorts. That's partially a reflection of the younger cohorts coming into these healthcare professions are more diverse. When you look at the breakdown of that, for example, if you look at the Hispanic Latino category of under 30, 14% is by far the biggest segment of Hispanic Latino folks in this chart by age group, which we would take to indicate that that's a growing segment of the profession. Does that make sense as far as how to read these charts? I see a few nodding heads. Okay. So let's go to the next slide, which is like another level of complexity. We've got some separations in the report by barriers to entry. This is roughly a proxy for education. So how many years of education it would take to enter this profession. And we've separated by low barrier, mid barrier, and high barrier. All of the barrier sets are noted in the appendices. There's also, I think, a slide at the end of this slideshow that contains that information. But one of the things that I want to pull out here is if you look at the high barrier, so that's the darker orange along the left, the Asian category has the steepest increase as you go toward the younger section, right? We've got a lot more Asian professionals coming into high barrier occupations, high education, high income occupations. That Hispanic Latino increase that I was noting on the previous slide, that is very much concentrated in the low barrier and to a lesser extent the mid barrier sections. So we're seeing disparate impacts in that increase in diversity that we see, like the white population's going down. We're seeing more folks coming in these other race and ethnicity categories. It's not the same across all of the race and ethnicities as far as how they're coming into the workforce or what professions that they're being represented in. That's somewhat a reflection of pathways, and I will note that it's not universal that everyone comes in at the same ages, as we heard a little bit earlier about the way people are coming into these professions. There can be people coming in at later times in their life, but in general, these younger cohorts, we're seeing a disparate impact in along the race and ethnicity lines. I don't know that we have either a recommendation or feedback about the mechanism as to why this is happening just from our survey data, but I think it's an important observation that we can take out of our data for folks like you to wrestle with and see if we want to try and confront those things. The next slide is just for questions and discussion. I will note that there are links, contact information, and appendix materials even in this slide deck. So you've got the slide deck as part of your packet today. I think Melissa also helpfully put things into the chat for us. We're happy to answer questions. There's also a lot of material in the report that we're not covering here. Yeah. Questions? Thank you for your time today, by the way.
Dr. Hemmings, go ahead.
Yes, hi, my apologies. I think I may have missed your explanation about the 2% threshold and how that was determined.
Sure. I would say that that's my that was my decision. That's largely not a methodological decision. It was an aesthetic one for that chart. There's not a threshold that we have a research basis for setting at. So when I think it was 2020, we published that same chart with a 5% or a 0.5% threshold, as Meredith noted. We changed that to 2, in part to highlight ones that had a bigger difference. But if that decision is not something that the committee agrees with, or you would prefer to see it with a different threshold, it's relatively easy for us to change. And that's feedback that we could take on board and even make changes before. We'll be coming back in January to ask for an approval vote. So I think we could make those changes before that if you would prefer us to go back to the 0.5%. And in fact, based on the conversation this morning, I mocked up a 0.5% version of it, and I can send that to committee staff and share with the group if you'd like to see it too.
Yeah, I would say that the current chart that is being displayed is, is skewed, right? Based on that 2% number. So and I think it's important to make sure that we get this right, because programs funding, how we actually determine what's happened in the healthcare workforce is going to be based on this data heavily. And it has a life beyond just our, today. And I think it's important that we get it right. And I think 2% really skews the data.
Okay.
I know that we don't necessarily want to see all that red, but if that's what's actually, happening, we need to make sure that it's accurately being reflected.
Sure.
Thank you, Dr. Hemmings. Surya?
Yeah, thanks. This is excellent information, gives a lot of perspective and understanding of the current workforce situation. Thanks for this data. I have a few questions regarding the slide 18, low barrier, mid barrier, high barrier. How much of it is reflection of affordability, the tuition, because the high barrier, certain ethnicities are able to engage in that high barrier occupations, and how much of it is reflection of just being able to sustain that many years of education and still able to survive the tuition cost barriers. Sorry, you want me to go ahead and finish my questions, or you want
sure,
me?
Go ahead.
Sorry, thanks. And on the same slide, we see, which is great, in the Hispanic and the Latino population, there is an increase in 20%. How much of that is a reflection of state-wide initiatives that's been taken by the legislature, or how much of it is a reflection of the reforms that, as a state, that's been implemented, is substantiated to this increase, or are they two separate things? And my last question is, are we planning on incorporating data from the certified professionals? Because a majority of the chunk also comes from certified professionals, maybe I would say, if not 50%. Licensure professionals are only 50% to the healthcare workforce. So is there any plan to incorporate the certified professionals also into this data, so we can have a better understanding of the shortages the state is experiencing? Those are my questions. Thank you.
Thank you, Doctor. I'm happy to take a first stab at those, and then my colleagues can weigh in. So on the education sort of expenditure front, our data set anyway is not well prepared to answer that question. I think that it's a really interesting one. I think that it would be a good one to coordinate with someone like the Higher Education Coordinating Council to try and get their feedback and maybe other sources for how those expenses are disproportionately affecting populations on their pathway to these professions. But we simply we don't ask any questions that would give us insight there. On the incentive sort of and work that Oregon Health Authority is already doing, or the state is already doing broadly to try and bring people into these professions, I think we have started doing some support work for the healthcare provider incentive programs to try and look at the populations that are being served by those programs, and maybe that can give some feedback on how effective they are for bringing in or for changing the diversity of the incoming folks into these professions. Again, that's not necessarily something that's reflected in our survey data as far as a question that we're asking about, did they use one of these programs to get here? But I think HCPIP could possibly give some more insight there. And then for certified professions, that's been an ongoing discussion since I've been with the program. And frankly, I think as a program, we would love to be doing more professions. We work occasionally with like the Behavioral Health Workforce Initiative, and they bring in data about the certified professions that are collected through MACBO. That's valuable data. We'd love to have it as part of our data set, but at present, our statute is calling for us to work with the licensing boards and collect licensure data. So it would be sort of a restructuring of the program, but we're, I think, very open to it.
Thanks for those answers. Sorry. The reason why I'm asking these questions, so we can incorporate this data that can reflect future recommendations from this committee. That way, I would rather address this front end than the back end, meaning create incentives for people to understand that, it can be affordable. It can be, if there is enough support from the state, rather than, yeah, there is a question, but still, am I going to get tuition reimbursement? Am I eligible for that at the later end? So addressing this front end, gathering that data will be more beneficial for our future workforce population. Thanks.
I just want to jump in really quick. This is Piper. Just to say, I really appreciate the questions of how to incorporate the larger context into the reporting that we're doing, because generally what we've been doing up to this point is just directly reporting on the data we collect. And I think that there's a lot of context that could help fill out and assist with policy decision making better than we are right now. And so the question of certified healthcare workers and kind of the why and the impact of these changes is just really helpful. So thank you.
Piper. Melina?
Yeah, thank you for this comprehensive data. I really appreciate it, and I'm happy to see. I think Andy and I had a conversation in September about adding more in-depth disaggregated data. So I'm very pleased to see that the subgroups are added along with the parent groups on ethnicity. But my question is, in regards to those subgroups, how did you come to decide which subgroups to add? So for instance, Asian, I love that Asian and Pacific Islander are separated into two different groups. The Asian category has 12 subgroups subgroups, and then Black African American 6, and Latinos only 4. So yeah, I'm just wondering how you came up with those subgroups.
Sure. Thank you for the question, Melina. So That particular set of subgroups, we're taking guidance from the Equity and Inclusion Division, who have created the Real D groups and subgroups, and the current set that we're using and that is in this report was, I think, propagated in 2020. They will update those over time, and I think the core of what's driving their updates is their analysis of American Community Survey data. So that's an associated census survey that is collecting data between the in the years between the decade collection of the census, and they're trying to make sure there's representation within the survey for significant populations that they're seeing within the ACS data. So those I think will change a little bit over time, or that's our anticipation. And in fact, the new set does split out some more subgroups, and it in fact includes even a new group. So I think that will change a little bit over time, but I think that would be the group to give feedback to if you think in particular that a subgroup is not being represented here. Equity and Inclusion Division would probably appreciate that feedback.
Perfect. Thank you.
And just to add to that, this is Piper. They're conducting a series of rulemaking for that process and eliciting feedback from communities in order to also inform which subgroups to add. So it's both based on community input and quantitative data.
And Melina, I don't remember if this morning it was you or Dr. Hemmings that asked about the choice of rarest race methodology and how that may impact things.
I did.
I might take just a second to address that as well. So that was implemented on recommendations from the Real D implementation guide, which again is from the Equity and Inclusion Division. I don't know if that recommendation may change over time, frankly, but I think it does have impacts on what we're reporting here, both at the subgroup level and at the group level. In the report itself, and I looked earlier this morning, I think it's page 34 in the report, but there is a graph that shows the discontinuity that I was mentioning earlier. Part of that discontinuity is driven by us now categorizing pretty much everyone into a distinct race by rarest race methodology, unless they affirm in a follow-up question that they consider themselves multiracial, and then they stay in that multiracial category. And it does have an impact on things like the Mexican subgroup is the third most populous subgroup in Oregon. So anyone who's multiracial and has Mexican as part of that multiracial makeup is not counted as Mexican. And so you can see things like in that trend graph on page 34, you can see that there's a drop in Hispanic Latino compared to previous editions. That's partially a response to that, but partially a response to people who might have chosen in the past to report distinctly as Hispanic Latino in the question, and now are answering multiple categories and being recategorized out of it when we use rarest race. So it does have impacts. I mean, the positive part of that impact is that there are a bunch of subgroups that may not have been represented before, or at least represented in a meaningful way in our reporting, who now, because of the rarest race recategorization, are seeing more representation in the report. So it's unequal in its effect on groups, but it does have an impact. Whether or not that's a sort of good impact or not, I don't know that we would make any judgment on, but it does change the way some of this is reported.
Thanks, Sandy. Committee members, are there any more questions or comments before we move on?
I just had a comment about the use of the rarest race mythology. And I was just wondering, have we considered looking at mitigation around the impact that, using that mythology may have? And also, I didn't see the actual survey. Is there disclosure around that question that would tell the participant that, we're using this mythology and the impact that it may have in terms of how they choose to respond?
So that on the latter question, no, there is no disclosure in the survey. In fact, I think the survey questionnaire as represented right now in the field, the question language predates the rarest race usage in our analysis. If the committee and probably more importantly, if the licensing boards think that we should be giving that caveat or giving that background to the survey respondents, I don't see why we wouldn't why we would resist changing those questions. But at present, it doesn't address that.
Thank you.
I think that as Piper said about community input, I think that this is an area where community input, committee input, public input for the process here and what the sort of outcome of what choice we make as far as methodology, that input to Equity and Inclusion Division so that they are hearing from folks about how this might affect your communities would be useful for them. They're making ongoing recommendations about how to best implement the RealD system, and we will, for the most part, be following those recommendations as closely as we can. So if they get sufficient feedback, they may change what their recommendations are.
Thank you, Andy. And Neelam, just so I'm understanding correctly, we are not voting on this today. We will come back for approval at January 8th meeting. Got it. Okay.
Yes, that's
Okay.
correct.
Okay, thank you. Thank you, Andy and team, for giving that presentation with us today. I appreciate it. If you could go to the next slide, please, Jessica. This is some resources. This is in the packet for you. Next slide. This is the contact information for all these wonderful folks, Andy, Meredith, and Piper. Next slide. Okay, next slide, please. Just some extra appendix slides for us. Next slide. Andy, I don't know, did you need to say anything about these appendix slides? Okay, perfect. Next slide. Get to our public comment period. Go ahead and keep going, Jessica. And next slide. Okay, are we at that? Are we here now, Neelam? Are we at the right spot?
Yes.
Okay, perfect. Okay, so we're at the point in our meeting now. We have some time set aside to talk about experiences with the coordinated care organizations over this last contract cycle. And we We'd really like to hear some feedback. And I know some of you have heard this said at the OHPB meeting, but we do welcome and appreciate public comment and public testimony. And it is one of the most powerful ways that we can demonstrate our commitment to profound listening. And we are not going to, I don't know how many folks have signed up to give public testimony. We're not going to put the 3-minute timer up there. We will just kind of be cognizant depending on how many people want to share, but we would really like to hear some of your feedback on CCOs in the past year. And if you can go to the next slide, Jessica, please. So the reason that we're doing this today is the Oregon Health Policy Board has asked us to gather input for experiences that folks have had with CCOs. If you were able to attend the OHPB session, I think that public comment lasted about an hour, maybe, if I remember, and it was very impactful. That's the word I'm going to use. But this information will inform the design of the next contract that OHA has with the CCOs. And also the feedback that we get today and through all these town hall sessions will help us better understand what drives the CCO successes, what drives the challenges, and develop a model that we can use across the next procurement process. So the next CCO contract is expected to begin in January of 2027. And next slide. So here's just some opportunities for feedback. You can see where we're at now. We had a public town hall on December 3rd, which was the Oregon Health Policy Board public town hall. There's going to be more feedback available at the January 7th meeting. There is also a public survey that is out, and there is a time set aside for CCO staff to provide feedback. Next slide. And next slide, Jessica. Okay. Couple of things here. We welcome all kinds of input from everyone, OHP members. Specifically, if people have input on these 3 areas, supporting the success of children, behavioral health referrals and partnerships, and social and emotional drivers of health, they're especially interested in hearing feedback on those particular items. And next slide. Perfect. Okay, here's just some discussion prompts for folks. We would love to hear successes, challenges, what kind of factors you think made your experience what it was. From your perspective with the CCOs, are there aspects that have helped improve care, communication, or health outcomes? What have you seen success in CCOs? And specifically, what do you think made CCOs successful? And what is making that success possible? And then maybe just sharing some examples of successful models that might be replicated across the state. So next slide, Jessica. I think that's our... Okay, here are some question prompts for providers, provider groups, and for our OHP members and partners. And I think what we'd like to do is open it up for folks to give feedback. If you would like to raise your hand, we can keep an eye on who's got their hand raised. Committee members, this is open to you as well to give feedback from your perspective on CCOs. So I think we'll go ahead and just open it up to the group. And Deepti and Jessica, if you can help keep an eye on any hands that are raised so we don't miss them, that would be great. Or if you just want to come off mute and share some perspectives. And Melina and Dr. Hemmings, if there's anything you'd like to add to the introduction of this feedback session, please feel free. I want to make sure I captured everything.
I think you did, Laura. You did a nice introduction.
Okay, so we'll open it up to folks. I'm not seeing any hands raised, but committee members, feel free if you would like I said, if you'd like to give some input, that would be great.
Do we have anyone here to give public comment?
Don't believe we have anyone signed up to give public comments. And if there are any members of the public here that want to give public comment, this is the time.
I do not see anyone with their hand raised.
I
at
don't
this time.
either. So again, committee members, don't feel shy about sharing experiences if you would like. This is feedback that we need to go to the Oregon Health Policy Board. I'm not hearing any.
I'm happy to share a couple of things that come to mind. So as a reminder, I'm a dentist. I work in a federally qualified health center. About 60 to 65% of the patients that I see are insured by the Oregon Health Plan. We work primarily with dental care organizations. So those fall under CCOs. Our primary CCOs are All Care and Jackson Care Connect, and under that, our primary DCOs would be Capital Dental, ODS, or MODA, and Advantage. And I think that two things that come to mind as far as where providers are experiencing administrative burden, a lot of the challenges for us come in following up on referrals to our specialist partners. And so for an example, if someone has a wisdom tooth that is causing an acute infection for them, that would, having that wisdom tooth removed would be a covered service under the OARs. But we usually partner with an oral surgery colleague because as a general dentist, I don't have the training to take out that wisdom tooth most of the time. And so we would fill out the referral process. The challenge though is that we see a lack of consistent information on when that referral is approved and where that patient has been approved to go. And that makes it hard for us to coordinate that patient's care, make sure that they know to call to schedule, make sure that we can provide follow-up or post-op care for them. Oftentimes our receptionists have to spend, have to call back to the DCO to check the status of the referral. And that's in between patients that they're checking in. I know they can spend up to 20 to 30 minutes on the phone on hold waiting to talk to someone to get an update on the referral. Patients kind of say, oh, sometimes I get something in the mail, but sometimes I don't. So I would love to see a greater degree of consistency and follow through on sort of information to both patients and providers on those referral decisions and information so that we can better follow up and coordinate care. And then as far as just a comment on credentialing, I'm sure that this is a consistent theme, but when we hire a new dentist, it can take up to like 3 to 6 months to get them credentialed. And so that's a time that a dentist might be ready to start working, but they're not able to see patients with OHP because of the credentialing process. So would love to see an expedited process for credentialing within that. I think that a win of the CCOs and DCOs is I think most patients know who their CCO is, which is a cool thing, right? So like I think the branding on the cards and having that come in the mail, I think most patients have a decent idea of who to call when they have concerns about that plan. So I do like having the cards with the phone numbers. Those seem very clear. And most patients that I talk to, have that card in their wallet. They can pull it up and see the contact information. So I will leave it there. Thanks.
Thanks, Elena. And I'll just And Judy, I'll get to you in just one second, just to tag on that a little bit. I'll just give my quick thoughts on that, Elena. Just because I live in the dental world too, and I agree with everything you're saying. As far as the credentialing piece, I agree. I think it's 60 to 90 days out now to obtain a DMAP number from OHA, which is really, really difficult. So it makes credentialing challenging, but thank you for your thoughts. I appreciate that. Judy.
Thank you. I would say a couple of things. First of all, we've had some great success with this ECO that we work with here in Astoria, in partnering with us to provide grants to begin services and make sure that we can get them well established and that they're meaningful prior to us just hiring people. So they've helped us support social workers for the first year of their employment with us, things like that. That's gone just amazingly well. Our biggest challenge, being in a rural area that doesn't have a lot of behavioral health resources, is when we have patients coming to our emergency department that need a higher level of mental health care. We can't get them transported to a place for that care, and we struggle. A lot of them need some sort of, they don't really need an ambulance to take them, but they need somebody with something more than just driving them to another hospital. And we struggle to get especially OHP patients out of here to a better, higher level of care. So if there's some benefit that they could provide to their enrollees, that would be great. Does that make sense?
No, it does. Are you talking about the NEMT, the non-emergent medical transportation benefit, or is it something in addition?
It probably is. I wish I had my social worker on here, my behavioral health person on here too. Let me see. Maybe she just sent me a text. She said that the challenge is that the CCO treats psychiatric transports differently than all other insurances, which then creates an inequitable access to appropriate levels of care in a timely manner. So when a patient really does need some sort of extra support to get there, our ambulance service isn't able to get them there in a reasonable amount of time for some reason. And
okay,
that's some of it's just based on the benefit that they have.
That's really good feedback. Thank you.
Mm-hmm.
I'll add to that, Judy, since I don't see any other hands raised. Another challenge that we've run into is specifically patients that use a wheelchair. So there's a lot of medical transport that for patients that are ambulatory, they can get to their dental appointment. There's awesome benefits. I love that. I love being able to schedule something with ReadyRide or medical transport. But patients that don't need an emergent transport to their dental visit, right? If they're coming to the dentist, they're not hopefully having a medical emergency. So they don't need the level of that an ambulance provides, but it can be hard to find non-emergent wheelchair transport. So I would add that as a gap that we've experienced in Jackson County.
Thanks, Elena. Eric?
Yeah, I just wanted to add to the transport for higher acuity mental health beds. Not only is it just a reimbursement of the transport that's the issue, it's that there's just no beds available, and then the patient gets stuck, and then since there's not like really active medical decision making being done, the transferring the facility is just on the hook for their care for a long time with people who need one-on-one supervision and other things. So it's like a whole log jam, a problem, and it ends up there's a lot of resources in that rural community that go towards this patient that are just solely just not reimbursed at all. And I don't know where the CCO comes into that, but like it's just hard all the way around for both the patient and the provider.
I agree. It feels like we treat mental health emergencies differently than we treat other emergencies, especially when a patient is in an isolated place and needs to go to a higher level of care.
Thank you for that. Thank you for the thoughts. Do we have, I'm not seeing any more hands raised. Are there any members of the public Any other committee members, new committee members that,
Laura, we have a hand raised.
oh, we do. Okay.
Melina Moran, I believe, has her hand raised.
Yeah, I just raised my hand.
Okay.
So I'm a provider in behavioral health in addiction medicine. And I could say that that there's definitely inadequate access to long-term residential facilities for people with substance use disorder. I think currently there's only 41, 47 maybe facilities in Oregon. And that's a huge barrier. So people go to detox for 2 to 5 days, and then where do they go, right? So putting them back into their environment where they came from isn't always successful, especially when they're wanting long-term care. So access to residential facilities. And with that, there's only one culturally specific residential facility. At this facility, they speak Spanish. There's Latinos working there, and it makes people feel comfortable. But with that, it's only for men. And so I think we need to see an increase for culturally specific care because, I mean, I could speak for my ethnicity. There is a huge cultural component to substance use and huge barriers and that are different than other ethnicities. So I think access to that. And then with the dental care, patients are waiting so long, my OHP patients, to get in to see a dentist. And yeah, it's just sad to watch. So those are a couple of things.
Thank you, Melina. Anyone else want to give some feedback or comments? Successes, challenges?
Sorry, I was trying to raise my hand, but I forgot how to do that.
That's okay, Megan, go ahead.
I wanted to weigh into on the behavioral health access, even for people that don't need emergency behavioral health services. If you try to refer them for counseling services or any kind of psychiatric co-management, the wait times are really, really long, incredibly long for them to get in. And we're also having trouble with physical therapy access. And at least on the South Coast, almost all the physical therapy offices currently will not accept our local CCO's payments. And so we're trying to manage their pain as best we can, but sometimes they might have a 3 to 6 month wait before they can even get into physical therapy for something that they really need. And then lastly, trying to access caregiving needs for our dual eligible patients can be really difficult rurally also.
Thank you, Megan. Other thoughts? Surya.
Sorry, I work in a hospital setting. I work at the state hospital, so I don't know how much. I do have some understanding, but not the ground level understanding of all these challenges. Out of my curiosity, how many of these CCOs provide treatment for substance use disorders, like able to prescribe like medication assistant treatment for any opioid use or things like that? How many of these facilities are even enrolled in that kind of service? And do they have an extended like programs like intensive outpatient program or partial hospitalization program? I know residential beds are much harder to create, but what about like programs like these? And I'm just for my awareness, I'm asking this question. Thanks.
I don't know the number that of clinics that provide STD treatment, but I do know that medications such as like Sublocade, Brixadi, buprenorphine are all on the preferred drug list. So all the CCOs should be covering those. So there is a way to access. I don't know the number of clinics.
The reason I asked because now nobody needs a DEA waiver to prescribe those medications. But I have noticed still a lot of I shouldn't say hesitancy, but a discomfort in prescribing these medications. So I'm wondering if there is any data in terms of like since the DEA has exempted that waiver, how much of these CCOs are actively prescribing these medications. But thanks.
I could just say anecdotally, locally, primary care providers are still sending us patients who need these type of medications just because of their lack of education on it. And so I think it's a education piece. Yeah, because they are, I mean, like you said, there's no need for a waiver anymore.
That's what I was hunching on, but again, I don't have data, so thanks.
Just in my clinic alone, we have 10 primary care providers, and there's only one currently that is prescribing those medications. And it's not because everyone knows they can, but it's a comfort issue, feeling like they don't have enough education to be comfortable prescribing it.
So I don't know if this can be replicated or not, but at the Oregon State Hospital, it's the similar situation. And I have led an educational program, and right now we have at least more than 20 plus practitioners who are much more comfortable in prescribing Suboxone or Sublocade or whatnot for for opioid use disorder under MAT. So maybe creating that awareness really helps. Reducing these numbers or people even needing residential facilities and can be managed in the communities much more stably versus relying on these long-term residential facilities, because these are we all know well-tested treatments that's gaining a lot of and there is a reason why DEA has waived this requirement. So thanks.
Well, I think it's more than just education. There's a lot of free courses you can take, and even like half the people who got the X license before like didn't prescribe, right? So you can actually take your course, get your X waiver, and half the people who got their X waiver didn't prescribe. I think the other part is primary care capacity. It takes a lot of work to do this work, and you already have a wait list anyway. And so you can't treat everybody that wants to be treated across the board. And I don't think it's a conscious thing. It's one of those things where it's hard work and it might be easier and you just stay just as busy by not doing
Absolutely.
this.
And definitely, I'm not alluding towards a 6-hour training online. That's not what happened at the state hospital. I gave multiple educational. It's just making them feel comfortable and having a better knowing of what this medication is, because it's methadone is different again. This is a much more safer medication, and we created a consult kind of service where help is always approachable. So I know it's hard to replicate this in the communities, and there are much more barriers to just these things, but something to think about.
There's also an Echo course, so it's just not the 6-hour one. So that's provided by the Oregon Echo Network, and that's free to anybody who signs up as well.
Again, all these courses only help so much, but having an in-house person, somebody who you can reach, makes a much bigger difference, and that's what created the success at the hospital, where I'm always available for them not 24/7, but during business hours to answer any logistic questions or clinical questions. But creating a consult service for the state per se with a team of few people who are always accessible. I know HSU does this to support via tele for certain remote counties where they have challenges in addressing their behavioral health needs. So something like that. Maybe.
Well, I was just going to add, not to change the subject, but we're getting a little short on time. I wanted to just add, from a CCO perspective, one of the successes that I have seen, and all the other CCOs, is with the implementation of the HRSN benefits that have been going on. I think the CCOs have done a remarkable job of getting these benefits implemented. I know for all care where I am, it is not easy putting all these things in place. But on November 1st, we were able to implement the housing benefit for people. And there is some strict criteria around housing these people that need this benefit. They have to have a comorbid condition along with the challenge of they're being close to being evicted. But to put something like that in place for a CCO that is, we're not just an insurance company anymore. And when I think about my 10 years with All Care and how we have evolved since when I first came to All Care, and we just administered physical health and transportation and dental benefits, and now I look at what we're doing in the CCO world. I think that it's remarkable. Not only that, our dental partners, the bill passed that dentists could do HbA1c testing in the office. I mean, who would have thought 10 years ago that we would be doing things like that today? So along with that does come its challenges. However, I tend to look at the glass half full perspective. And just when I think about how far we've come as CCOs and what we're able to do for our members, it really just does my heart good to see that, and to see what all the good work that all the CCOs have done across the state. That's just my 2 cents. Anything else anybody wants to add? Well, thanks everyone for your feedback and your comments. They will go to the Oregon Health Policy Board for their review. Jessica, could you go to the next slide? I believe that we are almost done. Okay. So our next meeting, January 8th. Please note the time. It will start at 10:30 on January 8th instead of our normal 9:30. We'll be doing an orientation from 9:30 to 10:30. I think maybe 9. I can't remember the time, Neelam and Deepti, for our new members. So please note the time change.
It'll be 8:30 to 10.
8:30 to 10. Perfect.
Right.
Okay.
Yeah, that'll be the
Thank you.
orientation, and we'll be sending out the invitation in the next few days.
Okay. Any final thoughts, comments before we close out for today?
This is Deepti. I just wanted to make a plug for what I put in the chat, and that's the link to provide written feedback for anyone who didn't want to participate today in the public comment. And it's also meant to be shared with your coworkers and communities. So just wanted to put a plug in for that. Thank you.
Perfect. Thanks, Deepti. Okay, everyone. Well, thank you. Thanks everyone for your thoughtful feedback and comments. And we'll go ahead and close out for today. And I hope everyone has a great holiday season and a great rest of December. And we will see you all